ketamine to get off of fentanyl. It works. Let's talk for a minute now about recent presentation at the American Society of Addiction Medicine meeting this past April. A group of collaborators, Dr. Andrew Herron, Tom Hutch, and Dr. Lucinda Grande, presented a paper that really outlined and built on some previous information substantiating ketamine in low doses can be helpful for withdrawal. Okay, let's back up a step. We've got patients on fentanyl. We have lots of patients using fentanyl. It's hard to get them onto suboxone, to get them stable, to then taper. We've talked on this channel a lot about strategies to do that, microdosing, macrodosing, all this sort of stuff, using NAD, using the bridge device. Well, we're really excited that there's good evidence now that even very low doses of ketamine significantly reduce withdrawal. The NMDA receptor antagonism really blunts opiate withdrawal. And there's other changes with both serotonin and dopamine release that affect the extent of withdrawal.
Okay, if you've liked this video so far and have learned anything valuable, please like, please subscribe, and hit the notification bell so you don't miss any new videos.
So what we're doing now is we're taking either an IV dose, say 0.5 milligram per kilogram IV over an hour, or even low doses. We have these little troches made. Each one can be a varying dose. In the studies presented at that meeting, they're using low doses, 4 milligrams, 8 milligrams, 16 milligrams orally. The bioavailability, that's only 20%. So if you're taking 20 milligrams, you're only getting, 4 milligrams or something? So what we're doing now in our clinic is we can help patients transition from fentanyl onto suboxone more quickly by using either IV or oral ketamine. This is easy for us because we're already a ketamine practice. So we have oral ketamine, we have intranasal ketamine, we have IM, we have IV ketamine here, and we're doing in-clinic detoxes. This is going to be more problematic for other clinics that don't have ready access to ketamine. But you can prescribe it. It's a Schedule III medication. Compounding pharmacies easily make this up. They make into little oral dissolving tablets, little waxy troches like this. The oral dissolving tablets are much better. You can even do home inductions with ketamine and fentanyl. How would you dose this? There's no established protocol on how to do this dosing. Even in their talk, they talked about different ways they gave it for different people. But one thing is clear is you have to have the ketamine on board before you give the bupe and cause some precipitated withdrawal. So most of these programs are basically giving like a low dose, anywhere from 4 to 20 milligrams orally, letting that kick in, giving a small dose of buprenorphine that does precipitate a little withdrawal. It's blunted by the ketamine. And then every few hours, every 4 hours, you could give a little dose and a little ketamine, a little ketamine, and a little suboxone. This works pretty well. And I think it allows patients to tolerate the buprenorphine dose coming up much easier. Most of their case reports involve the first day still being a little rough, then by the next day people feel good. So if you have access or your provider has access to ketamine, and you're reluctant or hesitant to stop using fentanyl because of a bad experience of precipitated withdrawal, look at augmenting that experience with ketamine. It really makes sense, but definitely breaking news. Ketamine is the way to go to get off of fentanyl and minimize the withdrawal symptoms.